we know that at AUA, there was a plenary session on the CREST study looking at sasanlimab with BCG and BCG-naive non-muscle invasive bladder cancer. Could you tell me a little bit more about that trial and what the findings were presented at AUA?
Sure. So the results were presented by Dr. Neil Shore at AUA in a plenary session. And this is really the first of this series of studies to read out. So this series of studies being the addition of immune checkpoint blockade to BCG in patients with high risk, treatment naive, non-muscle invasive bladder cancer. High risk is defined here as we really generally think about it from a clinical standpoint: T1 disease, high-grade Ta disease, or carcinoma in situ. Patients were randomized to one of three arms: sasanlimab, which is a subcutaneous formulation of a PD-1 inhibitor, plus BCG induction and maintenance, versus BCG induction and maintenance standard of care. And then there was a third arm, which was really not meant for the primary comparison, which was sasanlimab plus BCG induction with no BCG maintenance, just in the context of the BCG shortage, trying to see if some of the BCG could be eliminated. The primary endpoint was event-free survival, comparing the arms that had the maintenance in it. And then there are a bunch of secondary endpoints as well. And event-free survival is defined like it typically is in non-muscle invasive studies. So recurrence of high-grade disease, progression, so someone who goes from T1 disease to T2 disease, that's progression, of course. Persistence of carcinoma in situ, because remember, patients who start with carcinoma in situ have disease to start with, as opposed to someone with a papillary T1 tumor that's resected. That's sort of more of an adjuvant therapy as we think about it in the medical oncology world. And then, of course, death is included in that endpoint as well. And so what we saw in this very large international study was that there was an improvement in event-free survival with the addition of sasanlimab to BCG induction and maintenance. The risk of experiencing an EFS event was 32% lower with the PD-1 inhibitor added to BCG. And I think there was certainly a little bit of surprise maybe that this study read out, because we've been waiting for similarly designed studies to read out for quite a while. In the fact that we hadn't seen those readouts, I think there was some pessimism about that space, but really this does establish immune checkpoint blockade as potentially playing a role in this very early clinical disease state.
Absolutely. And could you walk us through the rationale of combining immunotherapy with BCG in this setting?
So as there usually is in combination therapy data in oncology, there's really two different schools of thought and two different rationales for combining treatments. One rationale is sort of the fancy scientific mechanistic rationale, and that is that potentially, there were some very early studies showing after BCG treatment, there's an increase in PD-L1 expression. So there was this sense that perhaps you can use this combination therapy to overcome that adaptive immune resistance. The other, more straightforward rationale is that these drugs have different mechanisms of action. They might, you might increase the likelihood that an individual tumor is going to respond to treatment by giving two non-cross-reactive treatments at the same time. And, which one of those explains the improvement in outcomes, I think it's hard to say for sure.
Absolutely. And so we have, impressive event-free survival data. We are still waiting on, the overall survival data that will eventually mature. What are your thoughts as far as the toxicity of adding immunotherapy, as far as grade 3, 4 immune-related adverse events, and even one death noted in one of the arms?
So this is a very early clinical disease state. BCG-naive, high-risk non-muscle invasive bladder cancer, high-risk patients, but a very early clinical disease state. In the control arm, the 36-month event-free survival was 75%. So we're starting off at a pretty good place. BCG, when given appropriately, is a really effective treatment. Now, there was an improvement, as mentioned, with the addition of immune checkpoint blockade, but that comes with some cost. And the cost is the risk for immune-related adverse events. that are similar to what we see in any clinical disease state. So immune checkpoint inhibitors don't care if a patient has metastatic disease or localized disease. They're going to cause the same side effects regardless. And so I think this becomes a very personal decision and, of course, a shared decision in terms of whether or not the risk of an event related to cancer is perceived to be high enough to offset that risk for toxicity. I think it'll be right for some patients and not right for other patients.
Absolutely. I think it will be really important. The same way that we counsel for even adjuvant treatment in muscle invasive bladder cancer, to have that discussion that the rate of grade 3-4 immune-related adverse events was over 10%. And it might not be right for every patient, but perhaps for some, like you mentioned. And so sasanlimab is a subcutaneously administered PD-1 inhibitor. What are your thoughts about this route as far as immunotherapy and the landscape of bladder cancer?
So I think in some situations, it probably matters more than others. So in someone who's getting chemotherapy plus immune checkpoint blockade, they're having an IV placed anyway. Whether or not there's a benefit to a subcutaneous approach versus just giving another infusion. I don't want to minimize the amount of time patients spend in an infusion unit, but the difference is probably not that marked. In this setting, there are a couple of really important points. One is that the other treatment is not being administered intravenously. So it's nice to have to not have to place an IV to give a treatment. The other is something that my urology colleagues have brought up to me, which I have to say I completely missed the boat on. And that is that these patients are not typically in infusion units. They're typically treated in urology practices. And once you take a patient with non-muscle invasive bladder cancer and place them in an infusion unit next to someone with metastatic cancer, their perception of their disease changes markedly. Right. And so I think there's a whole lot of baggage associated with that we don't frequently recognize. And being able to administer all the treatment in a different place, I think, has its advantages aside from convenience.
That's a great point. I think the patient experience of how they receive their treatment can certainly impact the stress and anxiety that they may carry. So that's absolutely really important. And as far as quality of life measures and other updates from the CREST trial, what will be presented at ASCO this year?
So there are a few important things about CREST, and one is the duration of response in patients with carcinoma in situ. And what you see in patients with carcinoma in situ, in patients who have a CR, the quality of CR is much better if you receive immune checkpoint blockade compared to if you don't. Maybe not that surprising because we see that in every clinical disease state. The quality of response to immune checkpoint blockade in metastatic disease is longer with immune checkpoint blockade than with chemotherapy. So we see that here, and I think that's important for patients to understand. The second is the quality of life data, and this is a big international phase 3 study, and quality of life instruments were collected throughout the treatment course. And important to note, of course, that there's no major difference in quality of life between the two treatment arms. Again, important in a population of patients that is asymptomatic to minimally symptomatic from their cancer itself.
Absolutely. And I'm glad to see more quality of life data coming out with all of these phase 3 trials. And then finally, as far as the landscape of non-muscle invasive bladder cancer, how do you think this fits in with all of our new approvals, more so in the BCG refractory space? How are we going to fit this in with all of these new treatments coming out?
So I think the first question that a lot of us had was this a one-off? Because as I mentioned before, there are other similarly designed studies that initiated before CREST where we didn't see the results yet. And so I think that was a potential concern. We heard a press release recently that Potomac with durvalumab also met its primary endpoint. So I don't think this is a one-off. And I think that requires us to reevaluate the role of immune checkpoint blockade in high-risk non-muscle invasive bladder cancer or BCG-naive from a clinical standpoint. There are other treatments that are coming, though. We have all these approvals that have happened or that are coming in the BCG exposed or the BCG resistant space. And all of those treatments are going to be moved earlier. And so where systemic therapy ends up when there's a lot of novel intravesical therapies, I think remains to be seen.
Mhm. Yeah, absolutely. It will be hard to interpret some, in some ways how to sequence best.